two major cell types. We have one cell type that makes up majority of the cell wall. And we have another one that kind of takes up the difference, or makes up the difference, I should say. All right? And here we go. Makes up the difference. So we have type 1 and type 2 pneumocytes. Type 1 and type 2 pneumocytes. Type 1 and type 2 pneumocytes. Trey, which one produces surfactant?
Type 2.
Yeah, exactly. And it is type 2 that contain these little dots inside of it. We'll call them lamellar bodies. Lamellar bodies. And when we talk about lamellar bodies, they help produce surfactant to decrease atmospheric pressure effects on the lungs, because remember, our lungs want to collapse. So that's kind of a good thing. I don't know. Let's try it. FISA, can type 2 convert to type 1, type 1 convert to type 2? Is there some rule?
Yeah.
Who converts to who?
What part? I think type 1 can convert to type 2.
Type 1 can convert to type 2? Okay, so sometimes you read different articles and they'll talk about stem cells. I don't want us to get into any of that. So let's make it simple. FISA, would you agree type 2 have lamellar bodies?
Yeah.
Type 1 do not have lamellar bodies.
No.
Type 1 make up majority of the alveolus, the walls. Okay, makes up majority of the cell wall surface. If type 1 don't have lamellar bodies, can they convert to a cell that has lamellar bodies then?
Oh, no.
No, but hold on. But a type 2 who has lamellar bodies, could those lamellar bodies be shut down and then wouldn't it look like a type 1 pneumocyte?
Yeah.
So who can convert to who?
Type 2 can convert to type 1.
Right. Does that make sense to do it that way?
Yeah.
All right. Try and simplify it as best as we can. Okay. So, perfect world. We have the type 1 pneumocytes, make up majority of the cell wall. Type 2, fill in the spaces. Type 2 contain lamellar bodies, which produce surfactant to decrease the atmospheric pressure effects on the lungs. That's kind of important. And by doing that, you're maximizing the surface area of the acini, and the larger the surface area, the greater the potential of gases to exchange. All right, that's good. That's good. But hold on a second. Munir, sometimes preterm infants, would you agree they don't, preterm infants, they don't necessarily always have the appropriate surfactant. Would you agree with that statement?
Yes.
Yeah. So they're deficient in what kind of cell type?
Type 2 pneumocytes.
Exactly. So Munir, let's do this. Let's turn around in this picture and decrease the surfactant production. Let's say this is a preterm infant. So Munir, what's going to happen to the size of that acini?
It's going to decrease.
Awesome. Because atmospheric pressure is going to start to crush it. And as a competent doctor, Munir, what are you going to do?
Blow it back up.
That's it. Oh my goodness. And when you give this kid oxygen, Munir, will all of it cross?
No.
No. And unfortunately, whatever does not cross immediately converts to a free radical. Now we have a problem. Because, Munir, do free radicals care what's in front of them?
Nope.
No. So would you agree it's basically somebody pulling the trigger on a gun?
Yes.
Munir, by laws of probability, what cell type is most commonly damaged?
Type 2 probability to try type 1s, there's a lot more of them.
Right, exactly, because it makes up majority of the cell wall. So, bam, bam, bam. Oh, man, all these bullets are flying, killing these different cells. Oh, no. So by laws of probability, Munir, again, what cell type's getting damaged?
Type 1.
And they make up majority of the lining, don't they?
Yes.
And because they make up majority of the lining and type 1's being damaged, can our body kind of help fix that a little?
Yes.
How?
Converting type 2 to type 1.
Awesome. And when they take that type 2 and they convert it to type 1, it's kind of the equivalent of a patch. All right, an equivalent of a patch. And the cell that they damaged, well, that's kind of going by the wayside. And Munir, when this starts to happen, are we going to immediately shut off the ventilator?
No.
No, because remember, ventilators do 2 things. They turn around and they not only put air into the acini, they also help push it across. Hey, but wait a second. So, Munir, while they're on that ventilator, are they going to produce more free radicals?
Yes.
And as they produce more free radicals and more free radicals, Munir, do you see a problem?
Yes.
And before you know it, they told 2 friends, and they told 2 friends, and they're starting to tell 2 friends. And as all of this is starting to happen, Munir, what's happening to the barrier or the thickness?
It's getting thicker and thicker.
Exactly. And if it's getting thicker and thicker and thicker, would it be harder for gases to get across?
Yes.
Oh, no. And if it's harder for gases to get across, let me open this up a little bit. If it's harder for gases to get across, we use a term called AA gradient. Big A is acini. Small a is alveolus. AA gradient. Big A, little a. Wait a second, Munir. Will the oxygen in the acini match oxygen in the blood when this barrier is created?
No.
Oh, no. So then if I'm looking at something to the top right, AA gradient, normal is 5 to 15. Munir, what would happen to the numerator in this equation?
It would go down.
So big A, right? And this is based
the
off of
numerator.
oxygen.
Yeah,
right?
it would be up.
Yeah, it'd definitely be up. And if you increase the numerator, what has to happen to that number?
It has to increase.
Exactly. So could I go above 15?
Yes.
Awesome. Wait a second. Munir, look at the screen for a second. Now, I've created this barrier, right? And would you agree it's in the interstitium? It's not in the tubes itself, the bronchioles.
Right.
So is there anything for this individual to cough up?
No.
No. So what kind of cough would they have?
Dry cough.
Oh, but wait a second, Munir. Look at the screen. Bottom center. Would oxygen have a hard time trying to diffuse across here?
Yes.
Because of that barrier. Are we restricting the oxygen from getting across?
Yes.
And if I'm restricting the oxygen from getting across, what kind of cough do they have? In this drawing.
Still a dry cough?
So anytime a patient has a restrictive lung disease, what kind of cough do they have?
A dry cough.
Oh, no. Have you ever read that in a vignette? I'm just making it up.
Possibly.
A dry, non-productive cough?
Yes.
Oh. So the second you read that, what did the test writer already tell you?
It's a restrictive lung disease.
Oh, my gosh. You got to be kidding me. Hey, so Munir, if you walk in a room to talk to a patient, and it looks like she has a tissue in her hand full of mucus, are you thinking restrictive or obstructive?
Obstructive.
Ah, come on. It's got to be harder than this. Nathan is disagreeing, saying, no, it's got to be harder. You got to be kidding. So if they tell me anywhere in that vignette, productive cough, what should you be thinking right away?
Obstructive, restrictive.
Obstructive. And if it's a non-productive cough?
Restrictive.
Oh, man. I thought pulmonology was supposed to be hard. Hey, but wait a second, Munir. Now, shouldn't this be around every acini throughout the lungs? Because if you give oxygen, it should go to every part of the lung.
Right. Yeah.
Yeah. Hey, if you did a chest x-ray, could this give a haze on the film work?
Yeah.
That's correct. Yeah. Is that why they say ground glass appearance?
Yeah.
Gotcha. So if I take a piece of glass and I run it across concrete and I scratch it, hence ground glass appearance. So, Munir, anytime a patient has ground glass appearance on chest x-ray, are you thinking restrictive or obstructive?
Restrictive.
And what's their A gradient?
It's going to be increased.
Munir, I'm not done with you yet.
I have to think about my answers first. I gotta
That's
think about them
okay,
for
that's
15
okay.
minutes. No,
Hey,
if you're not done with me.
Munir, you want to do an arterial blood gas on this patient?
uh, yeah, sure.
Okay, good. So after 3 femoral sticks, here we go. So, so here we go. ABG. Arterial. So Munir, arterial, okay? Arterial blood gas. I want to know what their PO2 is going to be. I want to know what their PCO2 is going to be. And I want to know what their pH is going to be.
Okay. So they'll have a decrease in PO2.
Okay.
They'll have an increase in PCO2 and a decrease in pH.
Kind of makes sense because what you're telling me is oxygen has a hard time going this way.
Mm-hmm.
CO2 has a hard time going this way.
Right.
And because they're retaining CO2, their pH is going to be low, right?
Mm-hmm.
Kind of makes sense, doesn't it? Uh-oh, you're quiet, Munir.
No, I said yeah.
Oh, I'm sorry. I couldn't hear you. Sorry. Okay, cool. But that's not what happens. You were good. You were confident. So, Munir, PO2, what's going to happen to it again?
PO2 would decrease.
Yeah, exactly. Awesome. I agree 110% with you. CO2?
Would decrease.
Yeah. Decrease or increase? What did you tell me before?
I told you decrease before.
Okay.
Or
Oh,
sorry, I told you it would increase before.
That's what I thought. Yeah.
Yeah.
So, but now you're saying it's decreasing?
Because you're going at me, yeah.
Oh,
I still think it would increase. Personally, I think it would increase.
okay. Help me out. Munir, how do we make carbon dioxide, which is a product of aerobic metabolism?
All right. You put it through the TCA cycle and electron transport chain.
Okay, yeah, we don't go to that biochem stuff.
Oh, that's
There.
What's needed to make carbon dioxide?
Oh, oxygen.
What do they not have?
They don't have oxygen. Okay.
So how can they make CO2?
Good point. So it'd be decreased.
There we go.
Got it.
And if I don't have CO2, what's going to happen to their pH?
It's gonna go up.
You got it. That is an arterial blood gas in a restrictive profile.